40 minutes. So earlier, and then I don't have to remind you. Okay, well, you have like 4 minutes short already. Hello, good afternoon. Shall we get started? Right, thank you very much for coming back. I think it's already 4 minutes past 2, so we wait for people to come back. Probably we got enough audience here. And thank you again for coming here to attend the afternoon's first session. I know that we enjoyed the morning session. I hope you had a very good break and lunch. My name is Houyuan Zhang, Professor of Management Science at Judge Business School, University of Cambridge, of course. And so we are actually based in the old Addenbrooke's. So there is a lot of things going on healthcare systems. And in this afternoon session, we have 2 speakers. And the first speaker is Dr. Jessica Barrett, and she's a program leader from MRC Biostatistics unit. So the talk of her the title of her talk is Landmarking Approach for the Dynamic Scheduling of Cardiovascular Risk Assessment. Thank you.
Thank you,
Jessica.
And thank you to the organisers for asking me to come and speak here today. So just to acknowledge the main contributors to this work. So a lot of the work was carried out by my postdoc, Francesca Gasparoni, who's since left for Novartis, in collaboration with Chris Jackson and Paul Newcomb, who were both at the time at the Biostatistics unit, and also with Angela Wood from the Cardiovascular Epidemiology unit, and David and Mike, who were also both at the Cardiovascular Epidemiology unit at the time. Everyone has since dispersed to new locations. So just to give a quick outline of my talk, I'm going to start talking about the application about cardiovascular disease, and then I'm going to talk about this method called landmarking for dynamic prediction. I'm going to then specifically talk about how that applies in the context of cardiovascular disease. And then I'm going to move on to discussing the scheduling of cardiovascular risk assessments. So how can we provide some kind of empirical evidence for how frequently we recommend people to have their cardiovascular risk assessments? And then just in the last slides, I'll talk about extending that with a net benefit approach to consider a more health economic model for determining those frequency of assessment. Okay. So starting with cardiovascular disease. So as we also heard earlier, cardiovascular disease is the #1 cause of death globally, with the WHO estimating nearly 80 million lives taken each year. So we're going to consider a specific definition of cardiovascular disease, including both non-fatal and fatal events, also stroke and transient ischemic attack. So for cardiovascular disease, the primary prevention strategy is to assess people's risk regularly and then determine whether they might benefit from some kind of risk management, which could be recommendations for more exercise or dietary improvements, or above a certain level of risk, it's recommended to start some kind of lipid-lowering medication, usually statins. So a cardiovascular risk assessment varies quite a lot around the world. So in the UK, current strategy is to assess cardiovascular risk every 5 years. That's a blanket approach for everyone over the age of 40. Risk is assessed using the UK risk calculator, which is Q-Risk. So that's a risk tool that was developed from primary care records in the UK and is updated every year. Considering a 10-year risk of cardiovascular disease. But you can see other parts of the world, they use different risk calculators. And also, for example, in Europe, there's now recently published a SCORE2 risk calculator. But the strategy there is gender-based. In New Zealand, how frequently they assess your cardiovascular risk will depend on your baseline level of risk. And they also start assessing risk at different ages, depending on your gender and on your ethnicity. So the Maori population in New Zealand, which have a typically higher risk of cardiovascular disease, they recommend an earlier start for risk assessments in that population. But here's a quote from the European guidelines, where they found that risk assessment is important to repeat risk assessments. They recommend every 5 years, although there are no empirical data to guide those intervals. So the idea behind this project was to provide some kind of empirical evidence for how frequently cardiovascular risk should be assessed. So there've been a couple of papers that have looked at this before. So this was a paper by Barrett in 2013. And what they did was they took two cohort studies. So they took the Tokyo and the Framingham studies, and they looked at what proportion of people cross which was at the time a 20% threshold, stratified by their baseline risk. So people, for example, people less than 5%, can see very few of them cross the 20% treatment threshold. So they recommended that the decision of when to rescreen should be decided according to baseline risk. I should say that since that paper was published, treatment thresholds have lowered. So currently in the UK, we have a recommendation that statins should be considered at 10% risk of your 10-year cardiovascular, your 10-year cardiovascular risk. So another more recent paper looked at using, again, they used a cohort study, and this cohort study had measurements of the most common cardiovascular risk factors. I can't remember how, I think they were measured every 5 or maybe every 7 years in this cohort. It's quite an old cohort. This was what's known as the Whitehall Cohort. It was a cohort of civil servants from the 80s and 90s. So they used a multi-state model where the states are defined by your level of risk. And they looked at the transitions between low risk, intermediate, high, and high risk individuals. And their conclusion suggested that uniform 5-year screening intervals could lead to unnecessarily long delays in detection of high-risk individuals. So I guess there's two sides of the coin here from those two papers, which is that people who are at lower risk don't necessarily need to be screened so frequently, whereas people at higher risk, ideally you'd be screening them more frequently because they are more likely to cross the treatment threshold sooner rather than later. And just a comment from this editorial in the Lancet Public Health calling for a more informed, data-driven screening strategy. So the data that we're using in our project is data from the Clinical Practice Research Data Link. This is primary care data collected from GP practices across the UK. So we're just restricting to the English data in our study because it has better linkage with ONS and with hospital data. So in order to prove our detection of cardiovascular events, we've linked to those other data sources in the English data. So CPRD covers approximately 6.9% of the UK population. You can see from the map that it's not uniform coverage. There are areas that are better represented than others, but broadly representative of the UK population with respect to age, sex, and ethnicity. Okay, so moving on to talking about some statistical methods which we might use to address this question. So I'm going to talk about landmarking for dynamic risk prediction. So the first question is, what do I mean by dynamic risk prediction? So this diagram illustrates a prediction model where you've got some measurements of your exposure, just a single one here, but could be multiple exposures taken at baseline. And you want to assess your risk of an event up to time L within some time window. So dynamic risk prediction considers the case that you might want to update that risk prediction after some time has elapsed, and knowing that the individual hasn't yet had the event of interest. So we've now got a new time of prediction, T-pred. We have a new measurement of the exposure. So now we have repeated measurements of time-varying exposures. And again, we want to assess our L-year risk of having an event within that prediction window. And as time moves on, again, we want to update our risk, given our knowledge that the subject hasn't had an event yet at the new prediction time, and some additional measures of the exposure. So the landmarking method is a very practical method. What it does is it says pre-specify the times at which you want to predict your event. You select only those still, well, I say alive here in the context of a survival model, or more generally select those who are still at risk of the event at each prediction time. And then at each prediction time, you predict you estimate what your current value is of your risk factors based on the measurements that have been observed in the past of those risk factors. And then you fit a survival model to that cohort of individuals still at risk forward into the future. And typically you would sense a survival follow-up at the end of the prediction window. So that's if you're using a Cox model for proportional hazards, it avoids making long-term proportional hazards assumptions about your data. So what this model does is it essentially I think of it as the model that does what it says on the tin. It kind of follows the question of dynamic risk prediction, separates out your past exposure measurements from your future survival follow-up, and fits a series of models at each prediction time. So how might you go about using that past information about from the repeated measurements of your risk factors, your time-varying risk factors? So using the example of systolic blood pressure here, there are various things you could use. You could use a last observation carried forward, which is just to take the last observed value of your blood pressure. You could take an average of all the previous measurements. So that has the advantage of, rather than relying on a single measurement with measurement error, you reduce your measurement error by taking an average of several measurements. But it does assume that blood pressure is essentially constant over time. Or you could use some kind of model, like you could fit a linear model to this data and predict what your current value is at the time of prediction. Or what we've been doing is you can use a mixed effects model. So you can use, rather than fitting a linear model to the data from each individual, you can fit a mixed effects model to the data from all individuals. And that allows you to use, through the random effects, to borrow strength from different individuals to improve the fit of your model. Okay, so let's think about applying this in the context of cardiovascular disease. So this diagram illustrates the model that we've used. So because we've got a cohort in our data set, we've got primary care data. What that means is that we have about 15 years of data, but we don't follow everyone up from the start of that. People are entering and leaving the data sets at different times as they register with their GP practice, as they leave their GP practice. What we've done is we've used age as the timescale, because there's no obvious study timescale to use. So the best timescale to use, we decided, was age, and that also enables you to fit age-specific cardiovascular prediction models. So using the landmarking approach, we fit a cardiovascular risk model at each age. So it's illustrated here every 5 years, but we've actually done it at each age, from age 40 to age 80. And what we do is we use, so in each model, so each line here represents one of those models. The diamond represents the time of prediction. And we use all past measurements of repeatedly measured cardiovascular risk factors, including blood pressure, cholesterol, and smoking status. So that's represented by the dotted line, and then the arrows represent the survival models, which are fitted up to 10 years in the future for 10-year cardiovascular risk prediction. So looking at some of the results from that model, what we can do, because we fitted a new model at each time, at each age, we can examine how that model performs over age. And what we find, so the overall C index at the top is the whole, the C index as calculated for the whole population. But you can also look at the C index by age. And so this is going to be lower than the C index for the whole population, because you're now only comparing individuals of the same age. So you've removed age as the factor from that comparison. But what we find, which is quite interesting, is that the C index actually declines with age until at the older ages, actually your predictions are C index of 0.5. So you're predicting no better than by chance, really, for those older individuals. So I'm going to move on now to talking about how we can extend that landmarking method in order to estimate the frequency of the optimal frequencies for how regularly someone should have their cardiovascular risk assessed. And I should say this work has been carried out by my postdoc Francesca. So the basic question is, when should I have my next cardiovascular risk assessment? Suppose I'm at my GP today. I've had my cardiovascular risk assessed. So the vertical line in the middle represents the visit to the GP. I've got my previous measurements of my cardiovascular risk factors, illustrated here by blood pressure. The way we addressed this question was to try and predict for an individual when we expect that individual to cross the cardiovascular risk threshold of 10% for considering prescription of medication. And that's illustrated by the horizontal line. And so we plan the next visit when that cardiovascular risk is estimated to exceed the risk threshold. So in order to do that, we've had to extend the landmark model to consider not only my cardiovascular risk today, but also my cardiovascular risk projected into the future. And I should say, instead of a 10-year cardiovascular risk, we've considered a 5-year cardiovascular risk. And that's just because of the limitations of the amount of follow-up. If we want to project into the future, we don't have enough follow-up to project 10-year risk 10 years ahead into the future. And so I'm kind of, so what's in that? So what's in this graph? So the dotted lines represent times at which I want to predict my cardiovascular risk. So the first one at T-pred, that's the current time. And so that's your kind of standard landmarking. You take everyone who's at risk at that time and you fit a survival model to predict your current cardiovascular risk. So of that cohort, we then look into the future. So we look at T-pred plus 1 year ahead, and we take a new sub-cohort of that original cohort of individuals who have not yet had the event, and we fit a new model. So now we're fitting a series of models ahead into the future from the current time of risk prediction. And importantly, in those models, we only use past information. So we only use the information that's available at time T-pred to predict the cardiovascular risk in the future at future times T-pred plus 1, T-pred plus 2. And we do that every year ahead for 10 years. So we're considering after 10 years, probably you would want to reassess someone's cardiovascular risk in any case. And so these are some of the results from that model. So this, what I've used here is just the results from 4 individuals in the data set, just to illustrate the results. And so you can see, because we're considering 5-year cardiovascular risk, we halve the threshold to a 5% threshold for considering medication. So the red individual at the top, at 40 years, which is where the current prediction time is, so their current prediction age of 40, at age 40, that red individual was already exceeding the threshold. And so although their cardiovascular risk is predicted to increase, we would expect that that individual would be recommended some kind of risk management strategy already at age 40. At the bottom of the graph, we have a purple and a blue individual with quite low cardiovascular risk. And those individuals are predicted to stay fairly level or maybe a slight increase of risk. But that risk is not predicted to cross the threshold anytime soon. So those individuals we would expect to be safe to leave their cardiovascular risk management in the near future. Whereas so the green individual here in the middle, so that individual starts off with a relatively high cardiovascular risk, although not above the threshold. We predict that they would exceed the threshold around age 46. So you might want to bring them in a little bit before that, say age 45 for risk assessment, for a new risk assessment. So I'm going to move on now to talk about bringing in some other factors into this question of when do we rescreen someone for cardiovascular disease. Because so previously that just considered when we expect someone to cross the threshold, but you can look at a kind of economic analysis, a decision theoretic approach, where you take into account reducing someone's risk of cardiovascular disease by bringing them in at the appropriate time, but also the medication burden due to the use of statins, also the cost of prescription of statins, and also the cost to the NHS of multiple risk assessments. So the benefits are the event-free life years that you spend without taking statins, as well as the event-free life years while taking statins, but modified by a disutility for the impaired quality of life. Actually, statins are considered a very safe drug, so that disutility tends to be very, very small. But there is a very marginal cost to the quality of life of taking statins. And then in the costs, we have the cost of taking statins, which is the yearly cost multiplied by the number of years that you're taking statins for, and the cost of each visit, which is CNU, multiplied by the number of visits that you're expected to have. And so our total net benefit is your expected total expected event-free life years, where we've multiplied. So US is the disutility, which multiplies the life years spent on statins. So that whole term is multiplied by lambda, which is necessary to equate life years with the costs, which determine the right-hand side of the model. So you need to transform a kind of life year scale to a cost scale. And so then the net benefit is your cost of having hopefully many event-free life years multiplied by the costs of the statins and the visits. And just to put things in context, we look at an incremental net benefit where we look at a particular scheduled tour, which might be a yearly or 2-yearly or 3-yearly schedule, for example. And we subtract the net benefit from not assessing anyone at all over that 10-year period. And we use some very particular parameter settings, which are motivated by the literature, by the economic literature in this area. So in order to calculate the incremental net benefit, there are various pieces of the jigsaw that we need to fit in. So using the approach that I previously described, for each individual, we predict when we expect them to cross the treatment threshold. And then based on the current schedule that we are interested in, so say based on 4 yearly risk assessments, we assume that statins are going to be prescribed at the first visit after the crossing the threshold. So we're assuming kind of that we can predict the risk of those individuals. We can detect the high risk individuals after they cross the risk threshold. And then we can use standard survival analysis methods to estimate the expected event-free life years not taking statins. So that's the integral of the survival curve, and from between the times we're interested in, so between the time 0 and the time of taking statins. And then the time on statins is the same integral from taking statins up to 10 years, where the S superscript on the survivor function indicates that that is a survivor function for someone who is taking statins. And we assume that those who are taking statins have a hazard ratio of 0.8 multiplied by their hazard compared to those who are not taking statins. And that is based on a meta-analysis of the treatment effect of statins from clinical trials. Okay, so there's quite a lot of different pieces that feed into this analysis. But so here are some results. So this result actually is just looking at the proportion of individuals split by men and women who are in the different risk categories at different ages. And it's quite striking. So at age 40, most people are at low risk. So low risk is, so on the 10-year risk scale, low risk, we're considering low risk to be at risk of between 0 and 2.5% of an event within 10 years. Whereas as you get older, your risk quite dramatically increases. By the time you're age 60 for men or 70 for women, the biggest proportion of those individuals are already at very high risk of cardiovascular disease, so above the 10% treatment threshold. And so these is now some results from the model. So sorry, it's quite small because there's a lot of information to fit into one graph. But so what we've got here is it's stratified. We've got 4 graphs vertically stratified by the level of risk. So if we look, for example, at the low risk, and this is just for women, I should say this graph, I've got the graph for men on the next slide. So for the low risk individuals, and we have the age of prediction running from left to right. So starting at age 40, you can see that the size of the bar is the proportion of the overall cohort. So you can see age 40, most of the women are at low risk of cardiovascular disease. And then the colors indicate what our recommendation is based on our model using this net benefit approach. So you can see that most of those low risk people, those low risk women at age 40, are recommended that they could be rescreened in 10 years. So it's considered safe to do that because they're at such low risk of cardiovascular disease. Whereas as the age increases, the proportion moves from the bottom graph to the top graph. So the top graph is the high risk individuals. And for those individuals, the frequency that we recommend screening to take place, the majority is every year, possibly every 2 or every 3 years for those higher risk individuals. And so you could use this model as a kind of individual approach, or you could use it to recommend screening strategies, because you can see here that there's empirical evidence here that it's optimal to rescreen higher risk individuals more frequently, and low risk individuals can be can be rescreened less frequently than the current treatments, than the current health strategy. In view of the time, I might just gloss over the picture for men. Essentially, for men, it's very similar story. It's just that the kind of transition from lower risk to higher risk happens about 10 years earlier, on average for men. So just to summarize, I've talked about a statistical approach to building a cardiovascular risk prediction tool using data from electronic health records. We've used a landmarking approach for dynamic risk prediction. We used mixed effects models for repeated measurements of time-varying cardiovascular risk factors, and also a net benefit approach for the scheduling of those cardiovascular risk assessments. So there's quite a lot of work to be done. So in terms of modeling the longitudinal trajectories, we're a little bit limited by the data because it's primary care data. So we only have measurements when the doctors decide to measure those risk factors. But it would be nice to be able to model the longitudinal trajectories more flexibly, so we're not making linear assumptions of the behavior of those risk factors over time. Also distinguishing non-fatal and fatal cardiovascular events, so maybe a multi-state model to be able to tease out your quality adjusted life years rather than just your event-free life years. And in future work, we want to look at some uncertainty. So again, because these individuals have different numbers of measurements of their risk factors, those with fewer measurements are likely to have greater uncertainty in their risk predictions. And I think that could be brought into this decision of when to reassess, because people who've had fewer measurements are going to have a higher degree of uncertainty in the predictions. And so you might want to remeasure more frequent, you might want to remeasure sooner for those individuals. And also looking at individual biomarkers rather than a full risk assessment. Could you get away with just measuring blood pressure instead of doing a full blood test for cholesterol and so on? Okay, so just for a set of wider acknowledgements for everyone who's contributed to this work in some way. And I'll leave you with a list of references. Thank you.
Thank you very much. We get it back. We still have 4 minutes for questions. Are there any questions? Just one. John.
Okay, thank you. Thank you. That was really interesting. I mean, I've got lots of questions, but 2 quick ones. So the uncertainty in the measurements, I was wondering, you know, you in the end take a point estimate of the threshold, whether it exceeds the threshold. Presumably, individuals who have much greater uncertainty associated with them, you'd want to understand how to screen them differently to those who are very tight in their uncertainty. So can you see how your models might be able to take into that account, that uncertainty? And then my second question is on the economic modeling. One, you don't include a factor about the cost of a cardiovascular. And so even if it's death, it costs the NHS something to deal with someone who's having a cardiovascular event that leads to death. So would that shift the economic considerations, given that they're quite small values for statins and other things? If you know, if you've got, even if you've got a 10% risk of a cardiovascular event, that's going to cost, and on a sort of, if you're looking at a systemic approach to screening, that's going to add a set of costs, even from the event occurring.
Yeah, I think so. So to address the first one, I think you're right that I think uncertainty is very important, because we have some individuals who just have one measure of blood pressure and some individuals who have 100. So the uncertainty, so I guess in traditional risk prediction models, you have a cohort of individuals who all have a single measurement. And so the uncertainty is likely to be quite similar for everyone. But using this kind of data, I think there's going to be a lot of variation in the uncertainty. And as I kind of mentioned it for future work, so we haven't explored that yet, but I think it would also be good to look at how that uncertainty feeds into this treatment crossing threshold. So I think you could probably, if you had the uncertainty in the risk predictions, you could kind of translate that into a kind of time window uncertainty of when someone is expected to cross the threshold. So yeah, I think that's really important to do. In terms of the economic modelling, so I should qualify what I presented here, that this is not yet what we would consider a full economic model. I think there's quite a lot of factors that we still need to take into account. I guess what we were trying to do is just look at the first step of how you could use the landmark models approach to develop some kind of economic model. So as I mentioned as well, we've looked at event-free life years rather than quality-adjusted life years. So we've equated, so essentially we set to zero any time spent with a non-fatal cardiovascular event. So I think that needs including in the model. And you're absolutely right as well, the cost of the actual cardiovascular event to the health service should be included as well.
Thank you, John. Thank you,
you.
Jessica. Are there any other questions? Yes, just 1 minute. Hello, Maria.
Would it be meaningful based on the measurements taken into account to the model to include also HES data from hospital episodes data, especially for like high-risk patients at a later stage in their life?
Yeah, so we've used, we have got linkage to HES data, and so we've used HES data to define the outcome. So I know studies have shown that if you just use primary care data to define the outcome, then you miss quite a lot. So we've used HES and we've also used ONS data. We haven't used any, for example, risk factor measurements taken in HES. I guess it's more, I think, so I haven't curated the data set myself, but I think that is possibly because the version of HES we have is the version that does, it's not a very detailed version of the HES data. So it does have the outcomes in, but I suspect it doesn't include all risk factor measurements taken in hospital.
That's great. I think probably there are more questions, but then the time is up for Jessica. Thank you very much again, Jessica. And our second talk is going to given by